A good clinician is going to be really comprehensive in the way that they look at the patient, and whether they can provide that care individually or not, it is on the clinician, the doctor who's doing that assessment, to let the patient know everything that they need.
Hi, I'm Amal Nergodkar.
And I'm AJ Peak.
Welcome to Healthcare 100, the ultimate playbook for scaling healthcare. Each week we sit down with operators, investors, innovators behind the fastest growing DSOs and MSOs, and even health tech platforms to unpack strategies and systems and capital structures that drive real growth. And also we get ask our audience, our panelists, one idea, 100,000 idea that you can implement right away in your practices or your groups. Thank you guys very much for joining us. We have Dr. Eric Tobler and Dr. Bruce Baird gracing us today on this podcast. AJ, you want to kick off with your first question?
Yeah, and I'd say today's topic is the $1,000 an hour schedule, unlocking kind of peak productivity per chair. And I think to get it kicked off, maybe starting with Dr. Tobler, just give us, the audience, just a little bit of your background.
Yeah. Thank you so much for having me. I'm really looking forward to this conversation today. So my name is Dr. Eric Tobler. I'm a dentist in Utah. Started off practicing with my dad and my brother, really a family practice. As I got out of dental school, we built that practice up and just continued to grow aggressively because we had to for all of us to join together. My dad had been practicing for more than 20 years in a 2-operatory practice where I was the janitor and eventually became a dental assistant. And so this family practice grew to the point that, or we had to grow it so that we could all work together. And as we had that momentum going, we just continued to grow by adding friends from dental school and other great dentists to the group that we were a part of, and grew that one practice into 10 in Utah. Eventually sold that to Mortenson Dental Partners, and I was with them for more than 10 years. Great group. I really, really loved being a part of that organization. And eventually I became part of the national support team on the clinical side. And so I really got to understand, going from a single practice to multiple to a big group that, each step of the way, I learned a lot about what it meant to be a leader, and specifically on that clinical side, I got exposed to just an incredible scope of practice and, clinical techniques and just philosophies about how to run a dental practice. That was really exciting for me. And then a little under a year ago, I joined Dental Care Alliance as a chief clinical officer. And I thought my scope and my expanse of understanding of dentistry was pretty good. And all of a sudden, it's continued to grow. And being a part of DCA has been an incredible opportunity. Again, like the clinicians that I work with are constantly surprising me with new techniques or strategies around the ways that they think about their business, as well as the way that they think about patient care. It's been really just an incredible gift to be able to be exposed to that much in dentistry. So that's my history.
Well, I have been practicing dentistry for 44 years, graduated actually 45 years, but I did put the handpiece down, but I've been working with dentists for a long time. I started a company back in 2004 called Productive Dentist Academy, and we've been sharing and teaching dentists, and I've learned an enormous amount just getting to interface with so many different dentists across the country and ways that they do things, and that's been a fun project that we've worked on. We've got 40 some odd employees. We do marketing, scheduling, in-house consulting, the whole 9 yards. And then I started, that's when Amal and I first met, was back, started Compassionate Finance in 2011. And just because I felt like we needed to help patients be able to find their dentistry affordable, as opposed to, if I don't qualify for Care Credit, I can't do the work. And so we were able to do that. We did over $1 billion in patient financing over a period of 10 years. We sold to AKKR 4 years ago, and they're continuing to grow, and I'm continuing to be on their not their board, but I'm actually one of the clinical, people that work with them. So, and I've always wanted to help dentists, and that's the part of the thing. I actually sold my practice to Heartland back in the day when Heartland only had 60 or 70 practices. And I was in my own way. I only worked 2 days a week for the last 14 years, but I was able to produce $2 million a year on 2 days a week. And so I was one of the top producers for Heartland, and I got to understand a lot about the DSO world and how it works. And then we started our own DSO, Lantha Dental Partners, and we've now since kind of joined forces with with another group. So we're having fun, and I'm really looking forward. And thank you so much for having me.
And to kind of get this kicked off, and we'll probably ask a lot of probing questions, and we'll start with you, Dr. Tobler, is, the topic being $1,000 an hour for the providers you work with. And kind of, if you could kick off maybe just what are the top three, what's the target when you're working with a doctor that's, has a couple of years of experience to either on an hourly basis or daily basis, curious which metric you use. What is the target in your mind? And then if you were to synthesize, what are the kind of three levers you kind of go to in your tool belt to get their productivity up?
Yeah, great questions, AJ. So that I love the title of the piece. $1,000 an hour. It's an amazing goal to shoot for, and within DCA, we have such a wide scope of how our clinicians practice, from the type of practice that they're in, specialty or GP, where they come. Generally speaking, for me, I focus on where the clinician is at today and how do we improve that. I try to not focus on benchmarks or goals, like across the board. There's just too much variety in the way they practice, where they practice, the type of support they have. So many things. And I think if we get too hung up on an individual number, it tends to, demotivate folks who are exceeding it, and maybe could seem even too on a table for somebody who's too far away. So that's, I guess, my own philosophy on that. I definitely track it and look at it and benchmark dentists to one another. And that's one thing I really, really do enjoy is when I talk to my clinicians individually about their performance, I don't talk about benchmarks, but I talk about here's where you're at in comparison to your peers. All of this is dentists. I'm a clinician at heart. I'm much better on the clinical side than I am on the business side. I'm a clinician who's learning the business of dentistry along the way, and it's been an amazing ride. I'm so grateful to be a part of it. But I'm a clinician at heart, and especially practicing, again, going back to my roots with my dad and my brother. At the end of the day, you better believe we would check in on each other. And there was that competitive, a little bit of a competitive, healthy nature there. And I think that when we can foster that, it really is, I think, one of the best ways to bring clinicians together, because it provides camaraderie, provides that, again, healthy competition. But it also, when you talk about performance, it brings up the next set of questions, which is, well, how are you doing that, and why, and how are you talking to your patients, And so, I think across our organization, we're definitely below the $1,000 per hour that we talk about here on the podcast. I think we're, probably in the range of somewhere. And also the other thing that's interesting about metrics like that one specifically is from one DSO to the next, from one practice to the next, every metric, there's always a nuance to how we measure it. And, a few key inputs make a big difference on how we compare to one another. But the way that we measure it, we're probably in that 6 to 750 range for the average production for our clinicians. Again, so many different ways to slice it. So I don't want to be too precise on that or focus on the number as much as I do want to focus on your other question, AJ, which is what are the drivers that we focus on? So let's talk about that for just a minute. For me, there's really a few easy ones that I start with every clinician, and that is, how comprehensive is your diagnosis? For our early doctors, especially, the amount of dentistry that they diagnose is less. And most of the time that's not because the patients in their particular practice have less dentistry to do. It's just that a seasoned clinician has the confidence and the depth of knowledge to understand the things that the patient needs, right? So if I'm a seasoned, confident doctor, when the patient comes in, I understand all of the financial pressures, all the social pressures, all the other things that the patient has going on. I consider those, but ultimately I'm going to give the patient the very, very best treatment plan possible. My diagnosis is going to include evaluation of their occlusion, ortho, their caries risk assessment. It's their medical history. A good clinician is going to be really comprehensive in the way that they look at the patient, and whether they can provide that care individually or not, it is on the clinician, the doctor who's doing that assessment, to let the patient know everything that they need. So if I don't do ortho, that's okay, but I should definitely let the patient know if that's an opportunity for them. I need to diagnose it. I need to help them find the right person to do it. So that's the first one, is a comprehensive diagnosis. I think that is a key when I look at the performance of clinicians and help them find opportunities to improve. That's one of the first areas I look to. Another one is case acceptance. And so when you're treatment planning, are you doing it in a way that's clear? Are you giving the patient like actionable data, not too much information, but just the right amount to help inspire confidence, to earn their trust? How much of the treatment that you're diagnosing and proposing for the patient, how much of it are they actually accepting? Um, and then I like to get into the clinical side. What is your breakdown of the treatment that you're doing? That sometimes provides opportunity as well. So those are kind of the key areas that I look at early on when I'm assessing performance for our dentists and trying to help them find opportunities to expand what they're doing.
Oh, excellent. Dr. Baird?
Well, it's I could talk about this topic all day, and probably and love to do it all the time, Eric. Those are spot on. Um, most people think the productivity comes from speeding up and doing dentistry faster, and I can be more productive if I just work faster. If I just do more single unit crowns and with a mindset of scheduling to fill time. I always joke that most people get on your schedule. It's like a dartboard. So I want an appointment. They just go boom, and they get on the schedule, and there is no rhyme or reason. I'm not sure many people were talking about productivity per hour before 2004 when we started Productive Dentist Academy. I just began thinking of that myself because I've got such bad ADD. I have to know every hour what I'm doing, and the average dentist is producing 475, 500 an hour. DSOs, there are some that are below that. There are some that are above that. But if you just look at $4,000 a day, I'm wondering what the dentist is doing the rest of the day. Because all of us would be finished by 10 in the morning. We'd be on the golf course. I'd have a tea time at 11. But the things that I believe, and very much similar to what you were talking about, Eric, is number one for me is comprehensive care, comprehensive evaluations. We started a new group called Clinical Calibration Institute. We just launched that actually about 2 months ago. And, the team can't schedule unless it's diagnosed. And it's getting everybody on your team on the same page, from front to back to hygiene to doctor to associate, getting on the same things. And it's easy to say you need one crown, your insurance covers 1,000, let's get started. Boom, that's 100% case acceptance. But on a comprehensive evaluation of a patient, I don't worry. I believe a healthy new patient flow always helps. And that way I can tell people exactly what I would do in my own mouth if it was me. Now, you're right about the younger docs just don't have the experience. They don't have they may have the clinical feel, but they haven't done it and they don't have the confidence. And so that's okay. What Clinical Calibration Institute is, we're trying to get everybody up on the same page. Back in the day, if I could go to a study club with a bunch of older docs that knew what was going on, I could accelerate my learning curve almost instantaneously. Within a year, I'm doing a lot of the things they're doing because I was exposed to it. And that's in a low cost. I'm not going to every seminar all across the country, although we've all traveled. I'm a 3.5 million miler on American. So I went to all these courses and still continue to do it. But case acceptance is a team sport. In my group, doctor has to be a great clinician, but calibrating the team where your philosophy coincide is super important in my book. One other thing that is, a lot of people don't want to hear it, is it's very difficult to be a comprehensive dentist if you're seeing your new patients in hygiene. I'm going to see you in hygiene, and I got 2 minutes to tell you what your comprehensive evaluation is. Or I have to even be more or less productive and send you back for another appointment with me to go through it again. And so my philosophy has always been, I want to see the new patients first. And we can figure out a way that they can still have hygiene, because the reason that that's being done in dentistry is because you don't have the right answers when the patient calls in and says, I want to get my teeth cleaned. Well, the right answer is absolutely, we'll get your teeth cleaned. Doctor wants to meet you first. And as part of our scheduling template, we have a spot for hygiene so that they can go from me into hygiene, as opposed to not having a plan where I would just always see these new patients in hygiene. And we were seeing so many new patients, I didn't know who was in the office, didn't know anybody that was there. So comprehensive care, you have to have the time to be able to diagnose and to do that. Another real key to the $1,000 an hour is literally scheduling to productivity. When we call that a point well. We've been teaching that for 20 years. We have docs that are at $1,000, $1,200, $1,500, $1,800 an hour. And it's not because they're working faster. It's they're a comprehensive care dentist. They're just putting it in the right place in the schedule so that they can be massively productive. But what's even more important in my mind, like myself working 2 days a week, I'm able to make more money and kind of condense my time so that I'm super focused when I'm in there, and I'm just 100% on point, whereas when I was working 4.5, 5 days a week, my production would drop. And we've seen that with our docs, and you've probably seen it too, Eric. I mean, it's like, we've seen it with our docs. They go from 4.5 to 3.5 and their production goes up because all of a sudden now they have this new energy, this new focus, and this new way of thinking. So those are the two really, really important things. One other is technology has allowed us the opportunity to do the dentistry that we really would want to have in our own mouth. I look at crowns and inlays and onlays, for instance. If you don't have CAD/CAM technology, it's either a filling or a crown. There is nothing in between. But when I ask dentists, what type of material would you want in your mouth? Would you want a composite resin, or would you want an indirect composite that's put in the mouth and has a chance of lasting the rest of your life if you take care of it? Every dentist says the same thing. Well, I'd rather have that. But yet, if you look at across the board, I could come into any practice and increase that practice by $300,000 to $400,000 a year easily per doc by just going, let's look at technology and let's look at technique, and what would you choose? They go, well, my patients don't want, your treatment plan goes from $4,000 to $13,000, but you're doing a higher end service. And in my mind, if I get to let the patient decide what's in their best interest, not based on money, but based on what would I do in my own mouth? I tell them, I say, well, this is what I would do, but we have other options. What we find is that patients really want to choose what's best for them. They usually do. And then, a whole nother conversation is about financing and how to get people to say yes. Well, people will say yes if they can become affordable. So those are 3 things plus that can help increase productivity in a practice almost overnight. So
These are fascinating pearls. I mean, my goodness, wow, this is gold already. We could stop right now. You guys could both drop the mics, and we could stop this podcast.
Sure.
This is boom, boom. I'm going to drop it. But one of the things that I've seen at Patient Prism, we've done record over 250 million conversations, right? And people are trying to schedule appointments, and post pandemic, what I've seen a lot happen is there's just not room on the schedule, especially for the right type of patients. And we're seeing almost 40% of patients are not even able to schedule an appointment in when they are like new patients, emergency patients, orthodontic patients, and somehow we don't have the room on the schedule to put them because somehow we haven't figured that out yet. So the block schedule model is something that I'm very interested in. Like, what do you do with the template and the block scheduling so that you could accommodate the right patients in the right chair at the right time, producing the right amount of revenue per hour? What's the secret?
In my mind, that's a point well. I mean, you appoint based on productivity. And when we do that, I don't know if that question was for me, but I'm going to throw it out there real quick. But I mean, I was working 2 days a week, but I had time to see new patients. I had time to check hygiene. I had time to do everything I needed to do. And I would venture to guess that 95% of all dental practices run behind. And they run behind because they use the ordinary scheduling, which is the X's and the slashes. Here's doctor's time, here's assistant time. Dentrix even calls that perfect day scheduling. Well, perfect day scheduling is a joke. I mean, and I used to tell people, I can't be in 2 places at one time. What's going on? And all docs say that. But the truth is, if I am in perfect schedule, where I'm here, then I'm here, then I'm here, then I'm here, what happens if I end up having an emergency patient show up? What happens if that turns into endo? What happens? You know what would end up happening, and it happens in every practice across the country? They decide when Bob comes in at 3:00 in the afternoon, they go, Bob, you know, we were going to do these 3 crowns, 2 up top and 1 on the bottom. Why don't we just do the uppers today? Because the doc's running an hour and a half behind. And so you end up de-producing. You end up trying to catch up, and that kills you. And so with a point well scheduling, we teach a system of exactly how to, and our blocks are part of it, yes, but it's not a static block. I see this all the time. Oh, we have 2-hour blocks, put something in there. Well, I don't look at it that way. I look at it as if I've got $1,000 an hour goal and I end up with 3 implants and a couple of implant crowns on one patient, and that's $8,000. I schedule them all day in one chair. Now, people say that's the stupidest thing I ever heard in my life, but I just reached my goal. I set the goal, and I only have 2 goals. One is to take great care of my patients. That's first. I can't do that if I'm running behind all day. And number 2 is to reach my goal. And when I reach my goal, I've reached my goal. Now, what do I do the rest of the other chairs? And the other 2 or 3 chairs that I work out of? I do all the other crap I don't want to do during the week. And so it literally is, you know, I believe it's the way to grow a business without increasing stress. I call it, if I can reduce your stress by 50% and increase your production by 50%, would you be interested? Everybody goes, well, yeah. And so, but it's really not that hard.
So Eric, what about the templating and then the scheduling, block scheduling model? What's best working with you guys currently?
You know, I mentioned earlier when we started off this conversation that one of the most interesting and exciting parts of my job is the exposure to just different philosophies throughout my career. And this is awesome talking to Bruce. Like talking about block scheduling, we are in your sweet spot right now. I can tell, like the passion is radiating from you when it comes to block scheduling. And you know, from my perspective, actually, I'm relatively new to block scheduling. Most of my career, I operated similar to what you were talking about earlier, Bruce. Emphasis on stacking the morning schedule as busy as possible, working in same day treatment. That worked well for me for a lot of my career. As I joined Mortenson, I was exposed to block scheduling, and we had, you know, certain regions who were really heavy into that. And then joining DCA, block scheduling is really part of our philosophy overall. So it's been an interesting journey for me, one step at a time, kind of learning the best practices and seeing some of those things. I think the area that I see block scheduling helping us right now the most, one of our key challenges as an organization, is we have such a need for patients need to get into our practice. We don't have the capacity in many cases. And whether it's new or existing patients, once they get into hygiene, our hygiene schedule is just so constricted. And, you know, I think that's something that as an industry, we're all facing to one degree or another. Hygiene is just a really, really challenging spot for us. And for our hygienists specifically, thinking about their own productivity, as we see the wage demands increasing in hygiene, it really, I think, makes sense for us to look for ways to help increase the productivity of our hygienists as well, because I want to be the best employer, period. In every region that I'm at, if I have a practice in that city, I want my practices to be the ones that every single clinician thinks to themselves, man, they're doing it right. I really want to be there. And the way that we do that is by, helping our clinicians be productive and then paying them for that productivity, right? And then that's, of course, there's a lot to do with culture and you need to have all the other pieces right as well. But if we can pay competitively because we're productive, that I think is a key advantage for us. And for hygiene specifically, I think ensuring that we block off time for our hygienists to be productive with SRP so that we're, otherwise the challenge that I think we're running into is that we're underserving our patients. We're underdiagnosing the treatment that they need because we just simply don't feel like we can get it done. And so if you don't feel like you can accomplish what truly needs to be done, then you start to minimize that. Even in many cases, I think it's even subconscious, but it's essential that we create space for our hygienists to get those SRPs done where necessary. And I think that's an area for me right now that we're really focusing on block scheduling to create that space for that to be done.
And tactically, I know the DSO that I helped found had the same struggles. How are you doing it or even experimenting to make room for new patients? I'm curious for both of you, just really in the weeds, because listeners are like, sounds great, but like, what are you trying to get a new patient into the schedule? Like maybe Dr. Tobler keep running, and then curious, Dr. Baird, just tactically, where do you put them and what do you coach the staff on the phones to say and do?
Yeah. Again, I don't think there's a silver bullet. Going back to most of my history as a clinician, again, a little bit looser on the scheduling side. The directive was new patients most of the time came through our hygiene. I was able to, our philosophy in that practice model was to have a really robust hygiene team. So more or less a 2-to-1 ratio of doctor to hygiene. So you had significant hygiene support. And then when it came to, getting the two connected, it was usually the new patient was going through hygiene. So with DCA now, within our organization, most of the time we have new patients going outside of hygiene first, like Bruce mentioned. The constriction is too tight. And, that comes with its own set of challenges. Like you mentioned, Bruce, you have to make sure to communicate it appropriately to the patient in a way that makes sense to them, that helps them still feel like we're taking care of them. Because most of them think about it exactly like you said. I need an exam and cleaning. And those two are kind of connected in their mind. And so looking for opportunities to do that, I think is one of the challenges, or that's one of the ways that we're going about it right now, is trying to work outside of the hygiene for new patients. Yeah.
Well, AJ, one of the things that I've noticed is everybody wants new patients. And I love a healthy new patient flow. And marketing for me is important as opposed to being involved. And I know a lot of the DSOs have lots of PPOs and all of that type stuff, and that's where they're getting their new patients. My preference as a comprehensive dentist and doing the things that I love to do, I always ask docs, what's your favorite thing to do? And they go, I love doing this, this, and this. Well, that's what we market to. And I don't care about the number of new patients. It's just the quality of the new patients for me. That saves me from having 30 new patients, of which only 4 need the things that I need because I'm running some special on hygiene or whatever. I tend to market to train wrecks because I love doing train wrecks. I love doing full mouth reconstruction, implants, and even though I'm not using the handpiece anymore and I'm not chairside, I still dream about it about 3 nights a week, which I'm hoping that's going to get less. Go down the road, but it's the quality of the new patient and it's the scheduling that allows the time. I can't remember a time where I could not see a new patient within 2 weeks, even though I was producing at a high level. In hygiene now, we're starting to see this oral systemic connection and the opportunity to be able to really change people's health and their lives And maybe our philosophy as far as productivity is going to change to where maybe it's an hour and 15, or an hour and 10, or an hour and 20-minute appointment. I'm okay with that. But then it butts up to the problem of, where do I find the hygienist? How do I find enough room to book this? And one of the ways that I was able to solve it in our practice was using lasers and doing laser periodontal therapy and LANAP surgery and that type of thing. So it became a production item for the doc. And so my hygienist became very, very attuned at perio. We were probably running 40%, 45%, whereas in most practices, you're seeing today 10 to 12%, which we know 60% have perio. So by changing the focus, I would also take out of the $8,000 LANAP surgery I was doing, I would put $1,000 of that productivity on the hygienist schedule when they scheduled it with me. Oh my gosh, it was like game over. I was doing, we were probably doing six of those surgeries a month, 6 to 7 surgeries a month. Well, you think about it, 6 times $8,000, that's $50,000 a month just doing that, or 60. And I'm like, I like this. Plus, I feel like I'm at the higher level of taking care of the patient. So yeah, there's a dilemma that we have. How do I fit this many people into this many slots? My preference is the funnel that comes in, I want it to be as focused as I can, if that makes any sense.
Let me give you a data point that I'm observing a lot over the last 12 months. And the data point, and we measure it because that's the company I run, is that there is a very high percentage of appointments set for hygiene, 70 to 80%. But when it comes to specialty, we're somehow half that, right? So hygiene patient comes in once a prophy, brand new patient, whatever it is, cleaning. Okay, come on in 1 week, 2 weeks, whatever it is. We're scheduling at 78, 80%. Now, somebody wants an Invisalign, somebody wants an implant. We're only scheduling at 45, 50%. Somehow we can't fit them on the schedule. And so I don't know what advice to give our clients on what do you do when, I've had a full arch customer call recently, one of our offices, and I get alerted every time somebody makes a big mistake, like telling a full arch customer they got to wait 6 weeks to come in for a consult. I get heart attack for that. I'm like, oh my God, really? And the office says, well, we don't have anywhere to put them. Where do we invent a column? Where do we put them? Especially if they're that valuable and there's nothing to put them on in the perfect schedule, where do we put them?
I love that. I'm looking at it from the standpoint of, that is when I first started in dentistry, I wanted to do everything myself. I was a micromanager. I had to do all the packing of cord. I had to do all of the temporaries. I had to do everything. And I did not become productive until I realized that my team was the most valuable thing that I had. And, to ask, what do I do with same day smiles? We would do CEREC full smiles in a single day. And how did I do that? Well, I found somebody who was phenomenal at designing, using a CEREC. They were awesome. I had to train them on anatomy and everything, but I set up an entirely separate room where I started marketing in the general population in the Dallas-Fort Worth area for same day smiles, same day veneers, whatever. Every Monday morning and every Tuesday morning, I would have a brand new patient that was ready to go for that treatment. And I would just prep them at 8 o'clock in the morning. I would leave the room at 9, 9:15, 9:30. And at the end of the day, I would see, well, that's a, $10,000, $12,000 procedure, but my time was 3 hours. My team took care of everything else. And all I had to do was come in at the end of the day and seat them. Now, they also learned what is a correct fitting restoration. We're not going to, so at first it was a little rough, but pretty soon we're producing 1,000 an hour in a fourth chair that I had that I wasn't even using. So it has to be creative, and you can't do it all yourself. You have to have a team. Like with starts I tell people most dentists don't have enough ops. if they're using technology, they just don't have enough options. I mean, I would put lawn chairs in there and park people if I had to, just to say, wait, it's coming out of the milling machine here in a few minutes and we'll put it in, because there is just so much opportunity out there. Being a dentist in today's world is like having your own ATM machine. The patients need it. It just has to be telling people what they truly need, doing it the right way conversationally, and getting to know the patient before you ever start getting to know them out. And that is just something that, to me, there's not an easy answer when you're doing things a certain way. If you change the way you're doing things, all of a sudden you start to find new options because you have time. And the biggest problem I see, Amal, is when you have docs that can't even check all the hygiene patients that they have with all the treatment that needs to be done. So it's kind of like, I would rather get them into hygiene after seeing me. They become part of our hygiene annuity, which the annuity is going to come through every month, and I can grab it when I need it. So
I'm curious, touching on something you both mentioned, case acceptance, comprehensive dentistry, and you're both in a really tough, interesting job. You're trying to influence dentists, and my dad's a dentist, and I tell people I couldn't tell him anything. But I got real smart at influencing him at age 60, and his productivity went up. And just curious, like, what are the technology, and Bruce, you talked about technology or words that work? Because you can put 10 dentists in a room and give comprehensive dentistry and have 10 different outcomes based upon the tools they use, the words that they use. What's in your tool belts, when you're talking to the average dentist, and I know there's not an average, but hopefully you get what I mean, either on the words that work or the tools that will help them. Okay, I got it. I'm comprehensive care, but now how do I get the patients to accept and move forward?
So before I answer that question about the tools and strategies I use, I'm so curious, like, how about for you with your dad? What was the key that helped kind of pivot in your relationship?
I had to be very Socratic. And I find that with dentists, you can't tell them anything. And they're very smart. They became a dentist because they want to be the boss. And so I early on, we went to Dr. Baird's program, and I did it through Socratic. Like, how does he do it? I don't know. I think it's impossible. I think it's terrible dentistry. Like, should we just go? And so we went, and then he's like annoyed that Dr. Baird's doing this, and he's doing it at high quality. So then, the next month was my dad's best month at like 62. So it was very Socratic of like asking questions for my father.
Yeah. I found it very similar. I think, anytime I'm trying to move the needle out from a clinical perspective with the doctors that I have the chance to work with, I think it first starts with clinical efficacy. Like, you need to have a depth of knowledge and an incredible clinical case for anything that we're talking about. So patient care always comes first, like the quality of care, the, peer-reviewed journals, or whatever it is that we need to rely on to make sure that first and foremost, we always feel really, really good about the quality of care that we're providing. That's kind of like a baseline. That if you don't have that foundation, then anything else that you say, forget it. So start with that foundation of great clinical care first as part of the conversation, I think has to be the foundation. Once you have that, then I think the other thing, similar to what you said, it's about collaboration. I sincerely believe that the cool part about being a DSO is that we have the opportunity to be better together than any individual of us could be on our own. And I have such a deep amount of respect and appreciation for my dad as my mentor in the clinic. He was like a legend, and still is in my mind, for so many reasons. But when he wanted to try out a new technology, he would fly across the country or go to a national or state dental association meeting, and he was talking to salespeople. And then maybe go to some friends from dental school or others that he had in his network. But it was really hard to collaborate, I think, in a meaningful way, clinician to clinician, about those kinds of clinical advancements. And of course, if you're talking to somebody who's selling it, they've got their own, there's always research done by some sponsored university or something. Like, we take everything, I think, with a grain of salt. You have to be skeptical about innovations and what really is going to move the needle. But if one has that foundational, clinical backing, And then I can talk to a few dentists who are using it and really get their take on how they're succeeding with it, how their clinical outcomes are better. Ultimately, we all want predictability in our dentistry. And that's one of the biggest challenges that we all face in this industry is that if I do a filling today, there's going to be recurrent decay 20 years from now. I don't get to just check out. And because I did an incredible filling with the best technology, the best techniques I could, it's still likely going to have recurrent decay in 20 years and 20 years if I'm lucky. And that I think is one of the fundamental things that is frustrating for most clinicians. We want to do the absolute best job we can. And so I think as we key into that desire of our clinicians, that's how we move the needle to, provide opportunities for collaboration. And when there is a great technology that helps us all be better, let's shine a light on that. And most people will just, be really attracted to that because we all have that desire, I think, in the profession.
Absolutely. Yeah, I mean, really, that question's a really, really good one. Back 30 years ago, the way we learned in dentistry, I mean, we might get on a plane, but there was always, you had a little study club that was your local study club, or you went over to Dallas, Fort Worth, and I went to a study club. And I learned a lot there because you had one-on-one. And then it became kind of everybody on their own, flying all over the country to all of these. Were getting marketed left and right to come to the Productive Dentist Academy, to come to this, to come to that. And it's hard to make a decision on what should I do. And today now we have Zoom, we have technologies, we have things that I can take. That's where clinical calibration is now. We don't just want to train the doc. We want to train the associate. We want to train the hygienist. We want to train your front office. We want to train your chair side. And we're doing it with people that do that on a daily basis. So, and we're doing it in a manner where we're making it affordable, like, I don't know, $900 or $995 for your entire team, a monthly deal that you're on Zooms, you're on stuff, and there's content and there's video and there's all of this stuff for a really minimal fee when you consider it. But you get to bring everybody. That old adage about, rising tide, it's true. And I believe when the team starts to get excited, that's when things really start happening. The doctors, I've been excited many times and my team wasn't, and nothing changed. So I realized I had to get them on the same page with me. And when they did, and I gave them responsibility, all of a sudden we began doing a lot of that, or whatever it was. Sleep is a good example. I mean, we started doing sleep before they were doing sleep. I mean, back, 20 years ago. And I took one of my team members who I just loved to death. I sent her to the best places around the country to learn about sleep, from John Remmers, from all these different people. She came back. She's the authority in my office on sleep. All I would do is walk in and go, "Hey, Jay, boy, it looks like you've got some pretty bad apnea. I think we've got some options for you." But they would have already known what you needed. And she would have already talked to him about it. So my time became concentrated. There's only so much I can do in a day. So, but yeah, it's definitely an issue. But I believe clinical calibration, getting people all on the same page, had changed the way I practice dentistry for my last 20 years. So, and we're just now figuring that out and saying, well, this is what we did. Why can't we do that for others and help them? So that's what we're doing.
I think the calibration conversation is something I was going to ask. I think you answered the question especially between the hygiene and the doctor, and making sure that they're working as a team and not opposing sides. People have to believe they're on the same team, and they just have to pass the ball and know when the assist needs to happen. Sometimes the doctor is the assist, sometimes the hygienist is the assist, but somebody's got to assist and somebody's got to dunk the ball. I mean, so I think you're so right about that, because that's where I think that the patient kind of loses trust in the process if they get two divergent messages, especially, and you obviously get divergent messages if you're running late, and that's another issue. Let me ask a quick question before we ask the big $100,000 question. Is the question that's close to my heart, which is AI, and I've been in it longer than all my gray hair is from AI right now. 10 years in it, and it's not the AI we do, but it's the diagnosis, the clinical AI, the clinical portion of it. And obviously, almost DSOs across the country are embracing AI technology, computer vision technology to diagnose, detect um, all the pathology that we apparently were not detecting in the past. And the road to comprehensive diagnosis is getting easier, at least technically speaking, with the advent of AI. So, Eric, I know you guys at DCA were one of the first big organizations to adopt computer vision clinical diagnosis AI at scale. Tell us, what are you doing with that? How is it improving, and how are you getting clinicians to kind of drink the Kool-Aid and start using it in a way that's going to improve everything?
Yeah, great question, Amal. Man, how do you get to clinicians to drink the Kool-Aid? Eternal struggle for me for the rest of my career, I expect. And I mean, part of it is making sure that the Kool-Aid is the right Kool-Aid, right? I think I view that as one of my most important jobs is we have to select the correct partnerships, the right technologies, and make sure that the things that we're investing in are the right things. Because it doesn't matter how good of a case I can make, if in the end it's not the right technology, then it's not going to work. So I think that's part of it is, making sure that we're selecting the right partnerships, the right technology to help drive what we're doing. When it comes to computer vision, um, I think one really key element to DCA's success with our partnership with Overjet has been having it integrated through our imaging software. When we can do that through, right now we have Denticon with XUweb, and right now the fact that those can kind of come together makes all the difference in the world. Previous to DCA, I was trying to work on a pilot program, and one of the hardest things we had is just getting clinicians to click outside of the PMS platform. Once you go outside the PMS, like maybe you're going to get, if you're really good at building a case for it, you might be able to get the shift, but it really is about creating smooth workflows. And, we're using the example of computer vision, AI for diagnostics, but it's true in everything that we do. We need to simplify the workflows, make it a streamlined process, get as many really well qualified, trained people outside of the dentist. That Bruce, you nailed that exactly right. Like the process has to be smooth outside of what the dentist is doing in order to help, make that adoption smooth. One of the things that I think is the most exciting opportunity that I see goes also to something that Bruce said that I just love. And that is when the dentist and their support team are on the same page, the dentist is able to be so much more productive and efficient in the way that we communicate with our patients and ultimately in our ability to build trust with that patient. So, I worked on a model that we called pre-diagnosis or pre-heating, co-diagnosis or pre-heating with the hygienist, where I, as the dentist, worked with my hygienist for years and they knew what I was going to say before I said it to a pretty accurate degree. And that was us working old school, like, going through case by case. I would diagnose and then come back after the patient had gone. I'd go back to the hygienist and say, did that make sense to you? Or they come to me and say, hey, Dr. Eric, this tooth, I thought you were going to recommend a crown there, but you recommended a root canal buildup crown. Why did it need a root canal? Like conversation after conversation, it took us years to get on the same page so that when I walked in the room, the hygienist had already told the patient, basically, here's what I expect Dr. Eric's going to recommend. And I could come in and, agree with that. And that just really elevated the patient's level of trust. So now fast forward to today, we have a diagnostic tool to help the hygienist and the dentist get on the same page, and dentists within the same practice and across the same organization. Like now we actually have this standard of truth. And it's not that it's right every time, but it's very, very accurate. So if we can start to use that as a communication tool to, help gain the trust of our patients and make our dentists more efficient, that's just such a huge opportunity, especially when we consider that our patients are accepting less than half of the treatment that we're providing or recommending overall. It's a matter of trust. In the end, our patients aren't fully trusting the recommendations that we're making. And I think AI has a huge opportunity to help with that challenge.
Thank you. Thank you for that answer. It's hard. It is hard. Change management's hard. Getting people to do different things is hard, especially when you're giving your team so much to do, so many tools to use, uh, and they're busy, right? And then now you're on top of that, you're layering on one tool after another. And you're absolutely right about the integration piece with XWeb Denticon and everything else. It's got to be one place. You can't have them click in 19 places to get to where they need to get to. AJ, you want to ask the ultimate last question to these guys before we end this show?
So imagine, Eric, very relevant for you. You're drop shipped into a group of 20 locations. And on this topic, you're giving a clinical leader or founder advice of like the one thing they can do on this topic to drive 100K of EBITDA, like now. I say 6 months, but as a business operational leader, we want it tomorrow. And something in this topic that they can go do, roughly $500,000 of revenue lift or, 100K of EBITDA, what is it?
I would say two things. Number one, I've talked scheduling a lot. And the one thing that I would say is if I can teach you how to do appoint well scheduling, how to schedule the productivity, if I can just do that with an understanding throughout the team, there's no question you're going to grow 300 an hour almost instantaneously. We guarantee a $300 an hour increase. Well, that's 480,000 on an average 1,600 hour year. So I know we can do that. I know that that's what I would do. But on top of that, I think just the verbal skills, working with the verbal skills of the doc. But ultimately, when I go in, and I just recently was in 5 offices, a couple months ago, and I started looking at their dental intel dashboards and stuff and how many fillings they were doing. And they weren't doing any inlays and onlays, even though they had Cerax, they had all this. So that was one thing I said, okay, guys, what material would you rather have? But the thing that I also found, which was just blew my mind, is a class 2 composite 2 surface and a class 2 3 surface and a class 2 4 surface. There's not a lot of difference in that. And a 2 surface is truly a 2 surface. When you break the embrasure, you're now going facial and lingual. You're going buccal and lingual. And I looked at their deal and they had 85% of their fillings were just 2 surface composites. And I go, if you're getting hosed by the insurance companies anyway, why not at least code it correctly? You know what I'm saying? Because you're talking thousands. And I literally, we found in a group of 60 DSOs, we found $18 million in difference by doing inlays and onlays and doing the proper coding for what you're actually doing. So, and I would rather do 2 surface, a class 2 or inlay or an onlay, 4 surface, whatever. It takes me 10 minutes to prep it. For me to do a 4 surface composite, it takes me 40 minutes. Well, why would I want to spend 40 minutes for something that is an inferior material in my mind? I would rather spend 10 minutes. Milling machines now, they're coming down to where they're cost effective. It's just a little change in our mentality. And all of a sudden you're cooking with gas, man. And you're doing it the right way. You're doing it what patients really prefer. And what I would tell the patient is, we can do a white colored, they'll ask, can I just do a filling? I said, well, we can. We can just do a filling. I said, it's probably going to last 8 to 10 years, However, there are other materials that have a good chance of lasting the rest of your life. Now, if you don't control the patient's risk factors, well, then that's not going to occur. But if you're looking at risk factors and you're getting them under control clinically, health-wise, then these restorations are better restorations. So that's where I'm focusing now. And that's really what we're doing with a lot of the stuff with clinical calibration. We're just really making people say, what is this? Okay, what is this? What would you call this? And it's just getting everybody on the same page. So that's what we do.
Love that. Dr. Tobler?
Oh man, this is a tough question. There's a lot of things that I would like to talk about here. I think, one is make sure and let the data drive your decision making. We have such a tremendous amount of data now. It's one of the biggest gifts that we have in the world today, but specifically in the DSO industry. We have more data to help drive our decision making than ever before. And with AI driving that data analytics process, we can have better outputs than ever before. So that's part of it when it comes to, determining strategy to move the needle. I think make sure that we have the data helping to lead us. But my one big idea, I think more than that, would be focus on engagement of your clinicians. Every other thing, there's tactics that can absolutely move the needle in 1,000 different ways. And I'm not even to 1,000,000 miles yet with Delta. So Bruce, I'm have a greenhorn here, but I've traveled across the country as a clinician, for myself clinically as a clinician, to be trained on different surgical techniques, updated on materials, the latest technologies, what across the board. And many of those I came back and implemented, immediately and had great success with. But what I came back with every time I was more engaged in my business. I was more engaged in, better patient care. I just came back more engaged. And that had to do with the course itself. But more than anything, it had to do with the interaction that I had with the other dentists from around the country who were there. And so we look as organizations, our opportunity is to look for ways to bring our clinicians together and to engage them in what they care about most. And when we do that, the sky's the limit. It's amazing how we find ways to just do better. It's who we are. As dentists, we've been through school for such a long time. As hygienists, anybody who's in this industry, we're in it because we care deeply. And then when we can find ways to really increase that engagement, I think that just is probably the most effective.
No doubt.
I think it's a great point to end this on, because at the end of the day, technology is great. I'm a technologist, but if you can get the people around you and get the team to kind of believe in the same vision of care and compassion and wanting to change people's lives, then we want to get them around a vision that's much bigger than just $1,000 per hour. That's not the vision, right? The vision is getting people treated, getting people seen, getting people access to care. Half of America hasn't even seen a dentist. And we are here not because a lot of people say, my God, the podcast we're doing is this is about money. It's really not. It really is about giving people, like you, Bruce, you said, the gift of health, which dentistry gives in more ways than ever before, because of the connection with oral systemic. But really, I think part of why AJ and I launched this podcast was exactly these ideas, because in the weeds, we're so busy as an industry treating patients and patient flow in and out and all the technologies. But sometimes slowing down and talking to you guys, it really puts it in perspective of like, man, sometimes it's the basics. Let's get doctors. It's a team sport, and the scheduling, and none of us talked about all this high tech stuff. We really talked about calibration of all of us, and then using the tools to really drive that, right? To bring us together. So I'm excited about AJ. Thank you so much for co-hosting this with me, and we're excited to have more conversations like these with everybody in dentistry and broadly healthcare, and really talk about the meat and not the veggies, although we need the veggies a little bit, but to mostly talk about the meat that's going to move the needle, basically, right? AJ, I mean, isn't that the hardest thing, is moving the needle? It's so hard as DSOs consolidate, you get bigger, moving the needle becomes hard.
No question.
Thank you both so much for giving the pearls of wisdom. Incredibly appreciative, Dr. Tobler and Dr. Baird.
Thanks, AJ. Thanks, Amal. And Eric, it's good to meet you virtually.
Yeah. Likewise. Thank you all so much. It's been a great conversation.
Thank you so much.